at 12.
Sarah, do you see it?
Yes, looks good.
Dr. Adams, I think we can get started.
All right, sounds good. Hello, everyone, and thank you for joining us for the Ohio AAP PMP, which is Parenting in Mealtime and Playtime program training about the female health triad. I'm really excited about our speakers in this topic. We have Dr. Kelsey Logan, who is the Cincinnati Children's Director for the Division of Sports Medicine. And we also have Maria Scazuzzo, hopefully I said that right, from Field, who is works for Dayton Children's Hospital as a female athlete registered dietitian. Before we get started, I really want to just remind everyone, if you're new or if you've been at previous trainings with us, the PMP program has a lot of resources, and we've expanded our resources to include not just the babies, and thus we're having this training on the female health triad, but also for through adolescence. And there's a couple opportunities to be able to access those resources for parents as well as yourself. We do have a great mobile app, but we have wonderful handouts and resources that you can provide for the families through your office. Next slide, please. We also have a toolkit, and this toolkit is amazing. There's so many topics. It is free, and we really want to encourage you to register and look around. It's easy to use. There's different modules. There's other webinars like this one that have been recorded and are now part of our toolkit. And it's also a wonderful way to get a good overview of what the program has. Next slide. The speakers have no disclosures. Next slide. And today we're going to be reviewing the components of the female athlete triad and be able to identify women that are at risk. They're going to describe how traits of the triad may influence injury risk and offer treatment recommendations for women with the female athlete triad. Next slide. So I'm going to hand this over to Dr. Logan. Thank you, Dr. Logan, for joining us today.
My pleasure. Sarah, thank you so much. And Sarah, can I just confirm everybody can hear me okay?
You sound great.
Okay, great. And I want to say a special thank you to Maria for joining us, because as physicians who are treating athletes with either disordered eating or an eating disorder, we cannot do this without a nutritionist with expertise in this area. So Maria, thank you so much. I will be very happy to hear what you have to say, because I always learn something when the dietitian's in the room. So, so my name is Kelsey Logan. I'm in Cincinnati. I'm at Cincinnati Children's, and I do sports medicine. I used to do primary care, med-peds primary care and sports medicine when I was at Ohio State. And now I pretty much deal with pediatric sports medicine, and a large part of my practice is counseling young women and their families on food and how to keep themselves healthy. I see variants of, athletes who are on the spectrum of female athlete triad are actually what we think of now as REDS, or relative energy deficiency in sport. We think of that now, and I'll explain that to you. We think of that with pretty much every female patient that we see now. And sometimes we notice this in the world of men's sports as well. So we don't want to totally ignore them, but because women have a period, and that is a biologic sign that we can measure, and guys don't really have that. This has been focused on females historically, but it's becoming more recognized in male sports as well. So you're going to hear mostly in context of how this is thought of in the world right now. It's still female athlete triad, but as you'll see in a few minutes, we're transitioning to another term called REDS that you'll probably hear about more and more. So what historically has been the female athlete triad? It is a low energy availability state. So simply not enough energy available to meet all of your normal needs, plus all of the energy that you're using while you exercise. This occurs with or without disordered eating. And we use that term disordered eating instead of eating disorder, because much of what we see is simply lack of education, knowledge, lack of awareness of what a young athlete, a young woman needs to support her body with the type of physical activity that she's doing. And as I'm sure Maria will talk about in her section, that eating changes depending on the sport and what the physical demands of the body are. So low energy availability is associated very, very strongly with menstrual dysfunction. In fact, that link is very, very well established in many studies. So you have low energy availability with some sort of menstrual dysfunction. In our world, usually that's a girl starts either spacing out her periods or dropping them altogether in training seasons. And then, of course, our big concern about that is that will eventually lead to low bone mineral density. These issues are not separate. They are interrelated. They depend on each other. And I'm going to show you a good model for that in a few slides. There is a spectrum of optimal energy availability down to very, very poor, a spectrum of normal menstrual function down to amenorrhea, a spectrum of great bone strength, normal bone development at that age, achieving optimal peak bone mass, to relative bone mineral deficiency for age. So I have some links on here at the top of the screen. These hyperlinks will take you to different statements that are free online that would be helpful for you just to peruse, that will have more in-depth information than I'm able to give in 20 minutes about female athlete triad and relative energy deficiency in sports, which we now term REDS. So the triad refers to girls and women, and it's focused on low energy availability and associated clinically relevant outcomes. So you can see that the clinically relevant outcomes that traditionally have been associated with the female athlete triad are some sort of diagnosable eating disorder, menstrual dysfunction, and bone loss. But as a person who's been doing this now for over 15 years, the eating disorder stuff has really, we've gotten away from definable eating disorders more to disordered eating, and menstrual dysfunction being a huge spectrum. And then in the pediatric world, having relative bone mineral deficiency instead of osteoporosis definitions has really changed how we're thinking about things. And so now in the sports world, we talk more about REDS, which covers a broader array of both physiological and performance outcomes in both men and women. And that's a key change. And it calls for more research on the impact of race, ethnicity, and disability, which female athlete triad has never addressed. So you have links to both of the initial statements on the female athlete triad and REDS there if you'd like to read more about them. The concept of energy availability here is really the crux. And energy availability for a woman who is an athlete and is going through periodicity, so different levels of training during the year, her energy availability is a moving target. And we always have to talk about, what are you doing for physical activity? What is happening in your daily life? And how do we match up your nutritional intake with that? So the energy availability, which we term EA, is how much energy is availability for daily physiological function after exercise training. How much is left over for your body to function normally? And optimally, we increase that with your physical activity, and it meets all of your energy expenditure, reproductive, and bone health needs. So these are related in that in sports, so we're not operating in a vacuum where we just tell a person what to eat and they eat it. We're not telling a person what to train and they adhere to that 100%. There are psychological pressures to perform. And then in some sports, there's a perceived need to maintain a very low body mass, gymnastics, running. And then that results in higher training volumes, lower intake, which results in stress hormones produced. And then we start to get into the physiologic outcomes that we don't want, right? The menstrual cycle starts to become abnormal. Then we have amenorrhea, which essentially is decreased estrogen production. Then we get into low bone mineral density. We know now for sure that that's associated with an increased injury risk. And what's emerged over the last decade is, unfortunately, that's associated with long-term increased cardiovascular poor outcomes. So here is the spectrum that we have typically used when talking about the female athlete triad. And you can see up at the top right, we have optimal energy availability, eumenorrhea, normal periods, and optimal bone health. And that's a spectrum all the way down to what we used to think of as osteoporosis, low energy availability, functional hypothalamic amenorrhea. So you can see though that everything comes from whether or not there's enough energy. So we have to have optimal energy availability to have both eumenorrhea and optimal bone health. Down here, as that energy level goes lower, then we start to impact our menstrual cycle and our bone. This, however, is the REDS diagram. And what you can see here is this is the narrow area that the triad fits in: menstrual function, bone health. But look at all these other things that we've started to understand. And the way this was discovered is that while studies were being done for the female athlete triad, we started to notice other areas of the person's physiology that were affected. And so the light bulb went off. Oh my goodness, maybe we're not looking in depth enough at the person's whole self. And we started to notice that low energy availability essentially affected every aspect of their functioning. So as you all know, normal menses is 26 to 35 days, divided into 2 phases by ovulation. We have a follicular phase, and then we have a luteal phase. Menstrual dysfunction has been the strongest link to relationship to injury. Essentially, any person who has menstrual dysfunction is going to be at higher risk for some sort of injury. We typically think about this with increased risk of stress fractures, but we're starting to see some data that looks at tendon, muscle, ligament injury associated with that as well. So in stress, we worry so much about stress fractures, though, that our screening has really been focused on whether or not somebody has a history of a certain number of fractures and the site of fracture. This is a diagram that I like to show my patients, that there's a range of disturbance, and most athletes are going in and out of different phases based on how much they're training. They may have normal function when they're in their off season, and then as they start to pick up training, they may still have a period, but still have anovulation. That can occur. And then in some sports, girls will start to drop their periods if they don't supplement what they're eating with their physical activity. So what's the prevalence of amenorrhea? Well, overall in the population, it's about 5%. In athletes, you can see in the various studies, the range changes dramatically. And that is based on lack of standardization of how we do these studies. So in certain sports, amenorrhea can be much higher, and certain lower, and it depends on how you measure it. It's highest in aesthetic sports, such as cheer, dive, gymnastics, endurance sports, such as running, and then in weight class sports, so sports where you're typically having to cut weight to make a different category. So in my mind, I'm seeing a patient, that's the first thing, like, what sport is it? What do you do? And then I know where to put you in the risk factors. So that's the first thing I want to know. So there's a decrease in energy availability, which drives all this. Simply, the expenditure outstrips the intake, either because the athlete has ramped up exercise, or for some reason there's decreased intake. Pediatricians are great at this, trying to figure out, like all good detectives, figure out what else is influencing this. Has there been a change in food supply? Has there been a change in habits eating at school? Has there been a change in stress at the home that's resulting in different food supply? Or have there been recent illnesses or medications that have affected intake? So all those things we're trying to figure out. And then what happens is the body figures out where it can cut calories. Where can we take shortcuts? And so the menstrual cycle becomes suppressed, and then eventually it's turned off. We used to think that a young woman had to have a certain percentage of body fat that would trigger a menstrual cycle, and that has been proven not to be true. Amenorrhea occurs with a common range of body compositions, and it's very individual, and there's a huge spectrum. And so we want to dispel the myth that the level of body fat is what triggers the period. It really is the energy availability. So how much energy is enough? And this is for sports medicine nerds. Maria and I deal with this all the time, but consistently in research, the cutoff seems to be 30 kilocalories per kilogram of fat-free mass per day. There are some folks who argue for a little bit higher with that. And as we do more research on REDS, I think we'll probably see that. There's some recent research that also says there may just be no cutoff, just an increased risk. So again, less dualism, as we had initially thought with female athlete triad, that we could put people in boxes. There's likely a wide spectrum of physiological health based on the individual. Okay, So estrogen protects the skeleton from bone resorption. That's why it's important. So I tell athletes that I don't really care if they have a period. In fact, it would be much better in athletic seasons if we did not have periods, just a lot less stress and anxiety for the athlete. However, the same estrogen that makes them have a period also makes them build bone and keep that bone. And so we want to know that they're having normal periods, because I want to know that they're having that good estrogen supply. It also stimulates bone formation. So if we have inadequate nutrition, we are going to potentially decrease that hormone supply. And then if we have a calcium and vitamin D deficiency on top of that, then we have an extra problem. Estrogen also, if we turn that estrogen supply off, then osteoclasts are going to resorb bone more. So we do think that there is a long-term increased risk for low bone mineral density for age or osteoporosis by making sure that optimally in a tween and adolescent and young adult woman's life, if we can ensure that they have a steady supply to estrogen, we can achieve that high peak bone mineral density in early life that hopefully we've created good habits to maintain. So stress fractures, this is what I see in my clinic every day. There's quite a bit of research. A lot of it comes from the military, because you literally have a captive audience that you can study, and they do a lot of physical activity. The research is clearly associated with higher, when you have menstrual dysfunction, you have higher prevalence of stress fractures, and stress fractures in higher risk sites, such as the femoral neck, the anterior tibia, those sites. So if someone has menstrual dysfunction, if you pick that up on your pre-participation visit or on your well child exams, you need to start talking about bone health and why it's important. These are other specific risks that we kind of keep our ear open for. If there's prolonged periods of exercise. So I will ask about extra training after their workouts, or in addition to their workouts for their sport. If there are any food restrictions, things that they just will not eat, don't like to eat. Is this a family that has different food styles? And so I ask if they have any food quirks, if there's anything in their family I ought to know about with food. Typically the parents give me a lot more information on that than the athlete will. Any sort of dieting for any reason. Have they tried to lose weight for prom? Have they for spring break? What have you? Early dieting. So kids who are dieting in elementary school, or if there's early sport specific training. So our gymnasts who are only doing gymnastics at age 9 and 10. Kids who have decided that running is their sport at age 8 and that's all they do. Those are red flags. Sudden increases in training. Now, we all see that with our regular athletes who are going in seasonal bursts for training, but this would be, for example, a person who's used to running 5 and 10Ks who then decides to train for a marathon. And then any sort of injury or time away from sport otherwise. Other at-risk athletes, essentially anybody who's subjectively scored or has to wear skimpy clothing for their sport. You can think about it that way. And you know your patient best if they start with healthy dieting, or what we think of as orthorexia, or trying to eat healthy, and we have to decide what eat healthy means to that person. That can evolve to even more restrictive weight control or increased exercise. So this is when I'm trying to decide whether or not we have disordered eating, where the person just doesn't know what they need to do, or if we have an eating disorder. There's some evidence that shows simply asking about restrictive patterns in eating is enough to tell that difference. Here's other risk factors, and you can link to this in the Female Athlete Triad consensus statement that was one link on one of the other slides. And you can ask these questions, and you can put these in your screening questionnaires, and we do these in our clinic. So in a workup, well, for a teenage girl, you got to make sure they're not pregnant, and then start to exclude organic disease if you have some of the signs and symptoms of that. However, you can do a bunch of labs and you're likely not going to find anything. You might see high normals, low normals, but families want to test for this, and there's not one test. Usually we're terming this functional hypothalamic amenorrhea. However, if you're really concerned about someone and you think they might have pronounce disordered eating, you probably need to get an ECG. So evaluation of this involves some assessment of energy availability. Realistically, in our clinics, outside of a formal dietitian intake, we're doing 24-hour dietary recalls. I try to get them to do a 3-day recall, but that's tough. Try to get them to do a log. And then if we really need to get down to it, we have one of our physiologists do exercise energy expenditure and try to assess fat-free mass. I do that with DEXA, not with calipers. This is just some cutoffs that you can use with BMI. You can also, I'm sure none of you have access to indirect calorimetry. We do that in exercise physiology labs, but you can also look for a low T3. And then if you're in a physiology lab or you have a dietitian who has access to looking at resting metabolic rate, you can have that measured. So these are just ways that we think about evaluation. Practically, we're doing dietary recalls. We're trying to get to know the patient in their situation and see what's best for them. We sometimes restrict training. And again, I put links in here because we wouldn't have time to cover all of this today. And I don't know that it would be helpful to you, but we go through, and I have these actually on my desktop when I'm working to go through the check boxes on what are the categories, what do they score, and should I restrict them for training? Because these are tough decisions to make. And sports medicine physicians are well accustomed to doing this, and we could all help you with this if you needed to. But you can see that we have categories for full clearance, provisional or limited clearance, and then restricted from training, which if we have to get to this route, it's an awful discussion that takes a team approach. This is the REDS model, which is very, very similar. There's red light, yellow light, green light, but they have a lot of the same approaches. And here is the consensus statement where you can see all the explanation behind that if you'd like it. So if they have low bone mineral density, we have to have discussions about training restrictions because it does affect their injury risk, their recovery time, and we have to talk about that in context with their sport. If we restrict an athlete from physical activity, we have to work with a multidisciplinary team to protect their mental health, to work on the things they need to change, and to make sure that they get back to training very safely, but gradually. And then this is the diagram that I think about, and I show families that if we're in low bone mineral density state, that's not going to recover in 4 weeks in time for the cross-country season. That is a years-long approach with the outcomes of estrogen continuing to promote bone health. We are looking at, the first thing is, can we change that energy status? Can we make that better acutely? And this is when I pull in folks like Maria, like how can we make that happen that will work with the athlete? And then we start to work on recovery of menstrual status. I cannot make a person have a period in 3 or 4 months. It takes many, many months, 6 to 9. But these are the goals here, right? We're trying to reverse any recent weight loss. We're trying to get them to have a normal menses, very, very tough sometimes, takes a team approach again. We're trying to get them to a safe BMI, and then we're trying to help them with what they need for their exercise energy expenditure. Treatment, by and large, this is increasing the energy availability, and that will reverse any physical symptoms that they have. Crucial in this, we've all seen this, magnified post-COVID, comorbid issue treatment is essential. If we don't treat anxiety, and that's what I see as the most significant issue affecting my teenage female athletes, if we don't treat that, they cannot address their energy availability issues with food. I did want to make sure that you understand medications. We don't use medications to do this. Estrogen replacement, even though it's very commonly done, especially in the OBGYN world, that has not been proven to be beneficial to bone and overall health. It also gives the athlete a false sense of security that they are now having a period and that they're okay. And that's not been shown to be helpful. Of course, we're not going to use bisphosphonates at this age. I wanted to bring your attention to the Choosing Wisely program that the American Medical Society for Sports Medicine took from the American Board of Internal Medicine. Number 3 on the 5 things physicians and patients should question is prescription of oral contraceptives as initial treatment for patients with amenorrhea or menstrual dysfunction. Just don't do it. Prevention. I love prevention. My heart is as a primary care pediatrician who wants to prevent issues in her athletes. This is education. By and large, most kids are going to have disordered eating, not an eating disorder. They're not going to understand what they need and energy requirements for training. We do an awful job of this in the medical world. We don't tell kids what they need to support their bodies while they exercise. Menstrual monitoring, what should be expected? Are families talking about this, or are they scared to? Calcium and vitamin D requirements, which are higher for kids who are exercising a lot. I like to do this screening at PPEs when I get the chance. I know you all can do these screenings at your well child visits in addition to your PPEs, so thank you for doing that. If one component crops up, let's say a kid comes to me with a tibial stress fracture, we're going to ask about all the other components and see if there's any red flags we need to chase down. And then ultimately, and I have a 10-year-old and 2 9-year-olds, and my 10-year-old girl is starting to have some cultural pressures for how she looks and performs. And we want to change that. We want to discourage unhealthy weight loss behavior, educate athletes that leanness or thinness does not necessarily equal performance improvement. In fact, it could make you worse. And in true pediatrician mindset, we want fun, skill development, and sport sampling to be part of their life, not individual sport specialization at elementary school ages. And that's all I have, and I'm happy to answer any questions at the end after Maria has talked. So thanks, and Maria, I'll pass it to you.
Awesome. Dr. Logan, that was an incredible presentation. Thank you so much for that. I love working with our sports medicine physicians here, and yeah, you just did such a great job. So I can go ahead and share my screen for everybody.
Yep, I stopped so that you could go ahead.
Awesome. Okay.
While Maria's doing that, I just want to remind everyone that if you have questions, please feel free to put those in the chat, and when they're done, we'll address each one.
Can everybody see my screen okay? Okay, great. So like I said, Dr. Logan, thank you so much for that awesome presentation. And Dr. Adams, thanks for the introduction. So like Dr. Adams mentioned, my name is Maria Scabuzzo Brumfield. I'm a registered dietitian at Dayton Children's Hospital. One of my primary roles as a dietitian here is I am the dietitian for our Center for Female Athletes, which is a newer program at Dayton Children's. It launched in spring of 2021. A fun fact about me that I'll sometimes share with families or coworkers. I was a Division I cross country and track runner for Miami University of Ohio. And then I love to run, and I always have. So I just didn't feel like I was done yet after college, and kind of continued and ran a couple marathons and got to participate in the Olympic trials in 2020, which was in Atlanta. And it was super awesome day for women's sports and just a cool experience. So sometimes I'll share that with families and patients. You know, I feel like sometimes it'll help them kind of better connect with me. Like, I know what you're going through. I've been there. Alrighty, for my part of the presentation, we'll just kind of go over female athlete nutrition, which, as Dr. Logan kind of mentioned, female athletes just in general, it's a very dense topic, and there's lots and lots of layers to it. So we'll kind of touch on energy balance, iron, calcium, and vitamin D. And obviously with energy balance, we'll kind of go into the food groups a little bit, talk about a few plate approaches that I'll sometimes use with athletes that I do see. So just a little bit about energy balance to kind of start off with, and Dr. Logan kind of touched on this as well, but it's just such an important aspect for the girls to understand that I have to make sure that I'm giving my body enough energy to meet all of the demands that I'm asking of it, and demands from my sport, and just demands from being a human as well. I found myself using energy over calories a lot with the girls. I feel like sometimes energy can be just an easier term to relate to, and there's just a lot out there about calories, and sometimes I feel like it can kind of be a negative term. So I find myself using energy a lot with the patients that I meet with. And as Dr. Logan kind of mentioned, a female athlete may not be in energy balance intentionally or unintentionally when they're expending more energy than they're taking in. So whether they have an increased training load, changes in their season, lots of different factors with that. And then we've already been over the female athlete triad. We know those 3 kind of points that go with it. Alrighty, so for energy requirements, I often in my practice don't give the girls a specific calorie number just because that number often changes so much. It ebbs and flows. It's a moving target. So obviously for documentation purposes, at Dayton Children's in our sports medicine department, we tend to use the EER with pediatric female athletes. And so we'll use a physical activity factor for that. And that's kind of the equation that I use. It's the one on our nutrition care manual as well. So again, I kind of more so look at like 24-hour recall. We try to do 3-day food diaries too, if we get them. Lots of times we don't have great compliance with it, but kind of looking at that. And then obviously we'll get into the plate approach too, and kind of what that looks like. And it looks very different for each athlete that we see. This is just a little statement from the CDC about the estimated energy requirement and kind of how it's used and why we use it. Typically, the way that I'll kind of put it in my documentation is calories per kilogram, and kind of looking at that. And then sometimes I'll kind of reference, we use the DRI too, so the dietary recommended intake, and I'll kind of look at what the DRI is, kind of peek at the EER, because obviously that's going to be further because it has that physical activity factor. And I'll try to look at both and then peek at that 24-hour recall. And, as best I can kind of see where are we at? And, is this going to be under what we need or over? Many times it's going to be under, and it's just that education piece for a lot of the athletes. Alrighty, so this is a plate approach, and these plates are really awesome. I don't use them specifically in clinic. Every girl is so different. Oftentimes we just do a lot of like verbal talking during my part of the female athlete clinic. Just kind of structure wise, our clinic operates, they see an athletic trainer first, then they see a behavioral health. She's a social worker, and then they meet with me. We have about 30 minutes for new patient visits and about 60 minutes with, 30 minutes with me at follow-ups, or if they really want to see me more one-on-one, we can meet for 60 minutes in just our nutrition clinic. But that's besides the point. For the plate approach, these plates were developed actually at the University of Colorado, their Olympic training site. They're developed by registered dietitians. They're a nutrition tool that sometimes, again, I'll just kind of talk about verbally with the patients. As you can kind of see, obviously, the food groups kind of shift a little bit with easy training, moderate training, and hard training. Like I said, I try to do, a gentle approach with these plates. I often, we won't talk about weight management or things like that. So again, I try to be as gentle as I can, but this is going to be the easy day. So for a lot of girls, we talk about balance. I don't call it weight management or anything like that. I'll just be like, okay, so, for where we're at in our season, let's kind of talk about what our meals look like. And then, if we notice we're kind of lacking in this food group or not getting enough of this at each meal, we'll kind of have that discussion there. But the biggest thing to kind of point out is that grain or starch food group. It's about 1/4 of the plate for just kind of our standard my plate we see everywhere. And then as our training load increases, you're going to notice that grain or starch food group is going to get bigger, because we know that that's our primary source of energy and preferred fuel source, which I'll talk about here in just a couple slides. But these plates are great. And just kind of as a side note, I have worked with eating disorder patients in the past, and there's this really awesome book called The Plate by Plate Approach. It's written by Wendy Sterling, who's a registered dietitian, and Casey Crosby. But they have basically, it's just a plate, and it looks just like this hard training day, and it has half the plate grains, and it has 1/4 of the plate protein just like this, and then vegetables, fat, and dairy on the side. But a lot of times with the girls, I don't even call this hard training day. I'm just like, we might need this every single day, kind of based on, where we're at and what that athlete needs individually. So a lot of this is verbal that I do with the girls, or we'll draw pictures too for visual learners. In our female athlete clinic, we do use the SCOFF questionnaire. And it's a screen for eating disorders. So basically, if they answer yes to 2 or more of these questions, they're marked as high risk for eating disorder concern. And they do this on a phone screen. So anytime we get a referral into our clinic, our athletic trainer will call the family. They do a bunch of other screens as well, but this is one of them that they will do for disordered eating disorder in particular. So there's the link if anybody's interested from the study that it came from. But I will say that, we have seen a fair amount of patients with eating disorders that we have then kind of referred out to. We have an eating disorder clinic here at Dayton Children's. It's brand new. So we've kind of shifted them over to that clinic if it's a more appropriate fit. All right, so I kind of went into a little bit about disordered eating versus an eating disorder. And I think Dr. Logan said this so great, is a lot with the disordered eating, it's education. They just need education to know, oh, I should eat a snack before my workout or before practice, and I should eat after. And I shouldn't skip school lunch if I don't like it. I should maybe pack my lunch. So a lot of it, can be, really prevented with that education piece. So I just have a little bit in here about disordered eating. It can include unhealthy food and body behaviors. It's serious and can lead to complications. But again, like a lot of times we can kind of help fix it with that education piece with, from multiple team members. So again, I think it's a range, right? So depending on the severity of it, there can be kind of a level of obsession around eating disorder thoughts and behaviors. But again, it's kind of differentiated between the two, which we'll get to on the next slide. Some examples of this could be skipping meals, misusing supplements, extreme focus on food, under eating or overeating, or maybe trying a fad diet just for lack of knowledge and education. So again, I always say it can be normal to think about food when we're hungry, but we just want to make sure it's not all consuming or controlling us. So eating disorders, we know that these are severe and life-threatening brain-based illnesses. That's a quote from the Emily program, an eating disorder facility in Columbus, Ohio. So eating disorder patients can experience serious disruptions in their behaviors, thoughts, emotions. These can lead to devastating consequences. But again, it's that extreme fixation on food or body that impairs daily life. So a lot of times we'll see dramatic weight gain or weight loss, extreme preoccupation with food, changes in food intake. So oftentimes, sometimes we'll see patients completely eliminate food groups, or, kind of start to label the foods into, oh, that's good, that's bad. And it just kind of spirals into this extreme energy restriction. Sometimes we'll see purging, restriction, or binge eating, abusing diet pills or laxatives, eating in secret, hiding food, feeling out of control with food, and then the medical complications as well for the signs and symptoms. All right, so one of the nutrients that I'll highlight with all of the female athletes that I see is iron. So we'll often talk about iron, kind of where it comes from, what sources of iron that there are. I've seen a fair amount of vegetarian athletes, so we'll kind of highlight those non-heme sources of iron, which basically is just going to be iron from our plant-based sources. But we know that iron is extremely important. Sometimes in female athletes, we'll see that energy fatigue, which could be from multiple different reasons, but it can be from iron deficiency. I know as a runner, I think on my college team, we would get our iron checked, and probably 80–90% of us all had low iron or low ferritin. But kind of back to the two sources, heme iron, we know these are iron sources from food. So meat, fish, poultry. The thing to kind of note about heme iron, it does tend to be more readily absorbed in the body than non-heme iron does. So non-heme iron, iron from plants, kind of your basic ones that kind of come to mind, dark leafy greens, legumes, hummus is one. Dried fruit has a little bit of iron in it, and then fortified whole grains and fortified cereals will as well. Typically, non-heme sources absorb the best when they're paired with vitamin C rich foods. So anything citrus, peppers, strawberries, etc. Normally, when I see the athletes, we say try to get at least 2 servings of iron rich foods throughout your day, if you're able to. Just as a note, calcium can decrease the absorption of heme and non-heme iron. So we just say kind of time your nutrients. So we'll say try to maybe do dairy like 2 hours later if you can, after you have that really iron rich food. But again, dairy is extremely important. So we'll get to that here in a minute. Actually, that's the next slide, which is good timing. So typically for vitamin D and calcium, I have a little screenshot there from the consensus statement that Dr. Logan had mentioned too. But, more or less, I tell the girls you need to aim for 3 to 5 servings of dairy per day. To make sure that we're meeting all of those needs that you do have, because we know it's going to be more because of your activity in your sport. We know calcium is essential for bone health, muscle contraction, and then kind of pairing that with vitamin D helps to form the bone and maintain the bone strength. So a lot of times in clinics, girls will be like, why is my bone health important? And I'm like, sit back and get ready, because it's such an important aspect. And so I love to share kind of that piece with them. There will be times that I will see, a patient with a dairy allergy, and we'll kind of have to think outside of the box when it comes to sources of dairy, which we can do on an individual basis. But kind of our main sources of calcium and vitamin D are going to be those dairy products: cheese, milk, yogurt, cottage cheese. Salmon does have some canned tuna as well, orange juice that's vitamin D fortified, eggs, and then any vitamin D fortified cereal as well. All right, so this is my favorite food group to talk about, grains and starches. And so with a lot of the female athletes that I see, I try to really pump them up about this food group, because I think just with my experience and the things that I've seen, I think this group can sometimes kind of be labeled as like, oh, carbs are bad, or, oh, I don't need those. Or, you have mom that might come in, and this isn't all the time, but just kind of, the things I've seen in our clinic, well, I don't eat carbs, but I know that she needs to. And then, patient kind of sees that and like, so then we have this whole, kind of talk about why this food group is so essential. And we know that this is the main source of fuel for athletes, but also too, just for humans, it's our preferred fuel source. And so typically 50 to 60% of total calories we want to come from carbohydrates. And like I said, really with this group, it ranges from 1/4 of the plate to half the plate. It really just depends on the unique needs of the athlete. And also it could ebb and flow in and out of season as well. In terms of, kind of how much carbs to eat before activity, which we'll get into in a little bit, it really depends on the athlete. Some do okay with just like 15 grams of fast acting carbohydrates an hour to 30 minutes before activity. And others, need closer to that 30 to 40 grams. It really depends on the kiddo. So we'll kind of take that into account too. And honestly, just how they feel when they try it. I'll have them call me after, be like, give me an update. How did we feel? Do we need to add like maybe some applesauce with that, banana or something like that? So we know that glucose releases from an athlete's hardworking muscle 3 times faster than energy from fat stores. So carbs are extremely important for that fast acting energy source. We know muscle glycogen and blood glucose are the limiting factors in performance, just meaning we know that those energy stores are going to go down the longer that we exercise. So it can be helpful to refuel if able, if your activity is really going over that 90-minute mark. So that's kind of sometimes when we'll tag in like sports drinks if we need to. So recommended sources, complex carbohydrates if able. So whole grain products, cereals, pastas, crackers, fruit, and then milk and yogurt do also have carbohydrates in them too. The thing with whole grains that I'll kind of preface with patients is obviously we know general nutrition, we want to aim for whole grains at least half the time, but whole grains are higher in fiber. So kind of with the athlete, if we're in that 30 to 60 minute time frame, I don't want you to do a ton of fiber because I don't want us to have to do any extra digestion before we're about to go do our sport. So sometimes we'll think of more like quicker fast acting carbohydrates like pretzels or graham crackers or something quick. If a piece of whole grain toast just was too much digestion for us. So again, there's kind of that caveat with athletes in that right before range. So this is actually a little screenshot from one of the handouts that we'll give to female athletes that we see, but these are just some fast acting energy sources for pre-activity. And if you'll notice, there's not a ton of reference at serving sizes on here. And I kind of did that on purpose because it really depends on the kid. I kind of think back to college. My husband ran cross country too, and he was more of like, I need a handful of pretzels, maybe half a granola bar, and I'm good, like 30 to 60 minutes before. I was like, I need a whole peanut butter and jelly, maybe a banana with it, maybe some applesauce too. So it really depends on the kid. And I've seen this with a lot of the females that I see. So I kind of always leave that out there. The main focus 30 to 60 minutes before is fast acting carbohydrates. Like I said, every female is going to be different. But also too, you know, some athletes, we will pair just a really small amount of protein if they feel like, you know, it's an hour, you know, maybe not the 30 minutes, we're doing an hour before, they might do a little bit of peanut butter on a bagel, and that's okay. It just is really dependent on the kid, but main focus is those carbohydrates. All right, so protein. I feel like this is always such a hot topic in the sports nutrition world. Kind of the message I'll kind of tell the females is, you know, we need adequate protein, right? We don't need excessive protein. We need adequate. We want to make sure you're hitting your protein needs through those real food sources of protein. So, you know, we know in the protein food group, meats, eggs, fish, dairy products. We know that the quickest recovery comes from both protein and carbohydrates. So I always share that, like, we need both carbohydrates and protein to help you adequately recover after our sport. So that's a big thing I'll, you know, tell the girls is we might have to think about planning ahead a little bit to make sure that we can nourish our body. Because if we're able to get protein plus carbohydrates within that 60 minutes, we're going to recover faster, be less sore. Our muscles are going to readily absorb those nutrients. So again, really protein we look at in grams per kilogram. So I'll use the DRI, so the dietary recommended intake, to increase needs. A lot of them are being closer to that increased need for their protein requirements, just with how active that they are. All right, so just kind of briefly with, I sometimes get a lot of questions about protein supplements. You know, we take the stance of, you know, we want to get real food sources of protein first. You know, we know the American Academy of Pediatrics does not recommend protein supplements in individuals younger than 18. So again, I'll really have that discussion if I do have a female athlete that comes in and is using one. So again, kind of the last bullet just kind of goes over how sometimes those protein supplements can really be offering excessive protein that's not needed, and then we worry that they're not going to get enough carbohydrates with it. So, you know, it's a conversation we'll have if we need to or we notice it. But just wanted to include that on here since it is a question that I sometimes have come up. All right, so for some post-activity snacks, this one's always fun to go over with female athletes. We'll do lots of brainstorming. I try to, you know, kind of match it to what they have access to, what's available at home. One of the, you know, common recovery drinks, chocolate milk. It's pretty cool. I always tell the athletes I see it's got a great ratio of carbs to protein, which is kind of ideal in that recovery. And again, you'll notice every option on here is going to have some sort of carbohydrate paired with some sort of protein source for that combination pairing. The ratio, the research in pediatrics, I've seen, you know, you can recommend anywhere from, for every, you know, 2 grams of carbohydrates, we want 1 gram of protein. So that's something you know, we can kind of look at food groups and it's easier to kind of convey to families. All right, so for fruits and vegetables, I always tell patients, you know, this is the color on our plate. We know there's lots of benefits to these guys, but with lots of patients I see, especially if we're worried about like inadequate energy intake, you know, we often recommend add cheese. drizzle them in olive oil. Let's mix in a little bit of butter. How can we think of ways to add extra like boosters to our fruits and vegetables to make sure we're getting enough energy with them? Avocado can be a great food just with a lot of the nutrients it provides, and it's also a little more energy dense than some of our other fruits and vegetables, but all of them are great for many different reasons. Fiber, gut health, all kinds of good things. Can just touch on fluids briefly. With fluids, for a lot of the females that come in, we use the holiday seeker method for calculating fluids. And then I'll tell them, the best way to really gauge our fluid intake is the color of our urine. I know there's obviously some, sports nutrition recommendations, which, we weigh ourselves after physical activity to assess how much, fluid loss we've done. Again, we don't often talk about that in our clinic, just to take the emphasis kind of off the scale and off of weight. But again, best way to measure it is our urine. Normally, water is preferred beverage for athletes in a sporting event lasting less than 60 minutes. But if the activity goes over 60 minutes, it is okay to tag in a sports drink for lost electrolytes and fluids. I always tell the girls they see too, fluid and hydration is so important. This last bullet, athletic performance can negatively impacted by as little as 2 to 3% body weight from fluid losses. This is a little graph for fuel timing. Again, it really depends on the kiddo. Lots of times we make fueling schedules for competition day. So generally 3 to 4 hours before event, we're going to have a meal rich in carbohydrates paired with our protein, kind of keep it lower fiber, lower fat, just because that's going to take extra digestion. So we'll kind of talk about that. And again, it's all kind of dependent on the athlete, but you see the example, oatmeal, you can add nuts, peanut butter topped with bananas, or a turkey and cheese sandwich. Again, really just depends on the kiddo. And then about 30 to 60 minutes before, like we mentioned, fast-acting carbohydrates, at least 15 grams. I've seen kiddos where we've gone up to closer to 35 to 40 grams before. And again, I won't tell them the gram amount number, we'll just kind of think of food examples. Again, just kind of like a gentle nutrition approach with the girls that we see, just to not draw emphasis on like specific numbers with foods or labeling anything. And then after the event, we want to do a snack. Or sometimes this can be a meal depending on when practice or games are. If it is going to be a meal within 30 to 60 minutes, we just tell them, make sure that you have a snack, like a bedtime snack, rich in carbohydrates and protein. So key messages. One of the mantras I'll tell the girls is that food is fuel, food is our friend. Some of them laugh at me when I tell them that, but I'm like, I truly want you to enjoy your relationship with fueling your body. It's so important inside and outside of our sport. So just allowing nutrition to fuel all the goals that we have in athletics and out. Every female athlete is so unique and so different. So lots of, personalization going on. And sometimes I'll use analogies with the girls, but just, we have to make sure we have enough fuel, because if we don't, it's going to slow down our engines. And nobody wants that. So just kind of stressing the importance of fueling and nutrition. And obviously we know the risks that can happen if we don't get enough nutrition in our body. So those are references, and hopefully I ended at an okay stopping point.
Thank you.
Yeah, no problem.
So much. That was wonderful, both of you. And I know I gained a lot of information. If anyone has any questions, please offer them in the chat. Again, I'm doing my shameless push about the PMP resources. I do want to also mention that the mobile app can be through Google or Google Play or Apple Store, the App Store. And even if it's after the program and you have some questions, feel free to, email our program director, Alex, who will be willing to, get that to either Maria or Kelsey and make sure. So I see about the mobile app, We are updating it after 5 because, as I mentioned in the beginning, that the PMP started with just the early age groups, and we're just now expanding. We're grateful to the Ohio Department of Health for doing that. But thank you for bringing that up, because we now I know for sure that this is something I think people will be looking for. The next question is for dairy intolerant patients who have poor intake of other dairy calcium. Do you recommend a calcium supplement specifically versus a multivitamin?
Yes. Yes. So for kids, it depends on their sport. So if they're a lot of load bearing, lots of lower body stress, then I will put them on a separate calcium and vitamin D supplement. In the kind of older tween adolescent age, I will have them do 500 of calcium and 2,000 of vitamin D a day. And we usually do that for several months. If they are recovering from a bony injury, they get that automatically. Other athletes to consider when you might want to supplement are athletes who are doing something like coming off of a swim season and going directly into track. That kind of, so bone density is affected by the type of sport that you are in. And so we pay attention to that as well.
Excellent. Maria, did you want to add to that?
Yeah, no, I agree with all that. I know our sports med doctor will order labs, and yeah, if vitamin D comes back, she kind of takes the reins on obviously the dosing and the supplements. But I'll sit down with the patients and just go through like non-dairy sources of calcium, whether we're talking about like soy milk or tofu, or we're going through a bunch of those other non-dairy sources. So again, they kind of vary. Almonds have a little bit, kale has a little bit, but we'll try to kind of identify like a good like plant-based milk option. I tend to really recommend the ones that are going to be higher in protein. So soy milk tends to be higher in protein. There's an almond cashew milk that actually has 10 grams of protein. So or pea protein milk too. Yeah, specifically pea milk has a really good amount of protein. So depending on the family and kind of what they're, interested in, we'll try to pinpoint down a good one, or a dairy-free cheese, that kind of thing. So
I love that you do that, because I talk a lot about calcium, the dairy-free calcium options, even in my pediatric practice.
yeah.
I do also, going back to the mobile app, the question was, are there resources for teens somewhere? Before I let our specialists answer, at the Ohio AAP, if you go to the website, and I have actually done this, which Dr. Logan was the creator of this handout. And there is a handout that is just one page, very simple for athletes and nutrition, but there's a number of other sport related handouts through not just the PMP program, but through our Ohio AAP website. Any other recommendations that people can get to offer their patients as far as resources? Okay, let's see. Go ahead.
A good dietitian.
Yeah, a good dietitian. Yeah,
they're hard to find, and folks who know about sports are really hard to find. And it's usually a few people in each community, maybe even just one. But, and I don't know, Maria, you'll have to talk about how you feel about this. Some of my athletes, especially in higher level club sports, over the COVID period of time, they started to access dietitians from all over the country about this. Now, I don't like all the information that they get. Because some of it's not youth pediatric focused, but you ought to be aware as pediatricians that your population is accessing new information from different sites that you would not have expected prior to 3 years ago.
Right. Good point. Good point. And our program manager, director noted too, Maria, thank you that you have created an actual handout through our PMP program that'll be coming out next.
Yeah. No, I definitely agree, Dr. Logan. I've seen that in some of our patients that'll come in that have maybe started following some dietary recommendations that they found on like an online website or you know, someone other than like a physician or a credentialed dietitian, you know, provided. So yes, we have seen that too.
That's a very good point. And then Dr. Logan, just to let everybody know, if you're not looking at the chat, she has included in the chat her smart phase for vitamin D and calcium supplements. Thank you so much. And then Alex said she's going to send that out email too. So we're just at 1 o'clock. If you do have any questions, I know that we can forward it to our specialists. And I just want to thank you both so much for this really informative discussion on such an important and concerning topic. So thank you very much.
Thanks for
Yeah.
having us. This is
Yeah,
great.
thank you
And I
so much.
appreciate you doing this information for older kids and adolescents. This is fantastic.
Yeah, well, I think it's a really good thing. And you both brought up the fact that they can get resources from maybe now, just in a click of a button, we can get resources. And because of freedom of speech, anybody can print or say anything. And opinions are one thing, facts totally are another. You want to get the right facts.
Yeah.
All right. Thank you again. And everybody have a happy holiday.
Thanks,
Yeah,
everybody. Y'all have a
thank
great day.
you. It's nice to meet everybody.